Welcome again. This is the VCU Department of Internal Medicine Grand Rounds. This is the week before Thanksgiving. Just a reminder, we will not have Grand Rounds next week, which falls on Thanksgiving Day. A quick other reminder before we get into our talk here, we are virtual. Please use the chat and the Q&A function. The CME code and the QR code will be reposted at the end of the session. Without further ado, let's get into our talk today. So today's session is hosted by the department. It is the State of the Department Clinical. This is the third of our series this fall. Today, we are joined by Dr. Patricia Sime, who is the chair of the department. She came to us in 2019 and continues to support clinical research and teaching activities. Dr. Christian Barrett, who is the professor of medicine in the Division of Hematology, Oncology, and Palliative Care, and he is also the current associate chair for clinical affairs, interim associate chair for education, and fellowship director for Hem-Onc. We're also joined by Dr. Zachary Gertz today. He came to VCU in 2012 to start the structural heart disease and is currently an associate professor and the Hermes Contos professor in the Division of Cardiology. Lastly, Dr. Georgia McIntosh, she's an associate professor in the Division of Hospital Medicine and serves as the chair of quality and safety for the department and has a strong interest in academic hospital medicine, QI, and patient safety. We look forward to an exciting update here. And if you need any help with technical assistance, please use the chat function. I will turn it over to, I think, Dr. Sime, Dr. Barrett, and Dr. Gertz might go first. Thank you.
So as we're waiting for Dr. Barrett to log on here, we had some technical issues. Maybe I'll just start off by, thanking everyone. This is an extremely busy clinical department. You do great work every day, and not just during the pandemic, but just around the clinics and the floors, taking care of lots of non-COVID as well as COVID patients. And I think this afternoon, what we'd like to do is just highlight some of the great activities that you may or may not be so familiar with. We can't possibly do justice to each of the 11 divisions because there are incredible things going on in every single division, but we've picked a few things to highlight, but it's certainly not all that goes on in the department. No.
So I can get started with just the first couple of overview slides if you want, Tricia.
Yeah, let's go ahead with that. Yeah.
So here is, not sure why it's fading back, but this is a slide just to show how much work we are all doing in clinic. Since 2017, we have had an increase in clinic volume every single year in total visits, in new patient visits. This persisted despite COVID, and I know Vimal has some slides for us on virtual, but even with shifting to virtual during COVID, we were able to keep seeing more and more patients, and I think that's a great testament to how hard everyone worked throughout. Next slide, please. And then just one slide for the AOP, which I think everybody knows is coming, opening in a few weeks. There's going to be a number of different services, 19 floors. We are present on most of those 19 floors. Yep, over 1,000 patient parking spaces, so presumably parking is not going to be a problem anymore. Food, all that stuff. One picture of what it looks like inside, and here's just showing where we are. Yeah, you can go to the next slide.
Zach, could you just click on that link, and there's a little video attached there? Oh, we lost the slide.
I hope you weren't asking me to click on a link because I wasn't even running the slides.
So Thomas, I think Thomas is running the slides. And if you could just, if you just go into viewer mode, so no. Okay. You just click on the blue link, it'll take us to a video where you can sort of see what it looks like for those who haven't had a chance to look at the actual building. And if you, yep, oh, perfect. So we don't have sound here right now, but that it is available on the web if you want to look at it. But I at least wanted to show you a little bit of the layout and the stacking diagram on this, which if we switch to the next slide, we can show everybody where the Department of Medicine sits. So Thomas, you want to close that out? Yeah, perfect. Thank you.
You can go back, Thomas.
So this is our presence in the AOP. As I mentioned, we are in many of the floors. I think that was it for my section, Christian.
So next slide, Thomas. So we can stop here. In addition to the growing and expanding patient volumes on the new site, certainly in the health system at large, the VCU health system is expanding and developing new partners as well. And as you can see, over the last several years, the footprint of VCU Health has expanded tremendously, particularly across the central portion of Virginia, but even to places further and further to our east, with 3 now hospitals within the system, but also numerous clinical sites in New Kent, Williamsburg, and a collaborative agreement between orthopedics of William and Mary, Petersburg, Prince George County, Fredericksburg, Hanover, and Winchester, as well as in the metro area, a number of clinical sites that continues to grow, along with partnerships with the health system between Sheltering Arms and Bon Secours as well. And then, while not necessarily part of a formal VCUHS network per se, we also have nephrology, who, for example, goes to many other clinical sites like the Center for Healthy Hearts, the Goochland Free Clinic, and then a number of dialysis centers around the region. Next slide. And so you can see fading in. If you look at these sites, you can see that we're very present and increasingly integrated into these newer facilities. With the example shown here, CMH down at South Hill, pulmonary doing teleconference consults with the ICU, hematology oncology having a full-time 5-day-a-week clinic down there staffed by Nimmer Al-Mualim, and GI expanding down there with clinical services in the outpatient setting as well. Tappahannock, hospital medicine staffing the hospital, essentially from a medicine perspective, as well as inpatient nephrology consults, renal teleconsultation, GI hepatology, and hematology oncology also going out there for clinical services. And similarly with Sheltering Arms, HMS out there doing active co-management and consultative services to the rehabilitation providers, along with a number of our subspecialties as shown here, establishing full-time clinics in a number of sites, including those in Williamsburg, Petersburg, Prince George County, and Fredericksburg. Next slide. So, and we can go to the next slide too. So nephrology transplantation, we're going to highlight specific programs, not to be exclusionary to all the great work that people are doing, but just to highlight some of the ways in which these expansions and new sort of delivery models are being implemented by providers here. So the transplant group, as shown here, next slide, has had some wonderful success in terms of the program, in terms of quality, but also a growing volume of service. And as you can see, the VCU transplant program for renal transplantation is certainly one of the larger programs in the country, and certainly therefore by extension our region as well, as you can see here. Next slide. And the numbers continue to grow, and that increasing numbers of patients was what fueled the expansion of these clinical services to meet the patients of our Commonwealth where they are. So the transplant clinics expanding, not just renal transplant, but liver transplant and others up into Williamsburg and Fredericksburg to try to, again, meet the needs of our community where they are. Next slide. Which gets to the concept of then telehealth. And you can go to the next slide as well for these transitions. So as you can see, 2020 was not just about, this is strange, I apologize, COVID, but as you could see in the next slide, coinciding with the pandemic was the expansion. Thomas, is it possible for me to take over the slides? I think that there may have been some embedded animation, which is almost going through it like a slideshow, it looks like. So with the COVID pandemic, there was an explosion essentially of telehealth visits. And you can see the internal medicine divisions were heavily utilizing the services in the order of 60 to 90% range in terms of our visits at times during the pandemic being done by telehealth. Next slide. And how does that relate then to the rest of the country? So you can see VCU during the early part of the pandemic in 2020 ranked 14th in the terms of utilization of these services, and that continued throughout the entirety of the year, resulting in us being one of the top telehealth users in 2020. Next slide. Now, in addition to just the necessity of meeting the pandemic changes, telehealth has been increasingly utilized amongst our providers to try to develop novel ways of improving the health of our community. And some example of programs would include the remote monitoring programs. One of two that we'll highlight here today would be the diabetes program, which is part of the effort of the endocrinology division here to try to improve the care of those with uncontrolled diabetes in terms of their diabetes and hypertension management, with the goal to not just improve the outcomes of the care, but also to for long-term sustainability by modifying behavior and increasing utilization. Next slide. And you can see the success of the program since its implementation last year has been quite substantial. The number of contacts per provider shown there were greatly increased between the RNs, the pharmacists, with less contact relative to the others in terms of this remote effort on part of the physicians. However, with their monitoring and the help of their extended provider network, the quality of the care was evident by an improvement of the hemoglobin A1Cs and at the same time, decreased utilization of the emergency room services, which the patients felt they would have been using had they not had the availability through this remote monitoring program of provider access. In addition, it had the added benefit to other patients because it improved the capacity of the endocrinology clinic by virtue of freeing up space during the pilot. Next slide. Another similar program was instituted, again, out of somewhat necessity with regard to the pandemic to maintain bed availability and sort of access to the hospital facilities. And so we were, the effort of the group from the geriatrics department, from the hospital medicine group, was to really improve sort of post-discharge follow-up and through remote active monitoring, essentially 24/7 with providers on call to target those with high rates of likely post-discharge complications and readmissions, including diagnoses such as respiratory disease, heart failure, and complex care. And the intervention would continue for about 2 to 4 weeks post-discharge, launched right around the start of the surge of the pandemic in 2020. And again, to decrease utilization and to improve hospital throughput. And indeed, they found great success with not only a reduction in readmissions, but also in terms of reductions in length of stay per case. New slide. Other ways in which telemedicine health has been implemented recently has been, for example, in the GI program with hepatitis C, doing remote monitoring and chronic disease management within the Department of Corrections. And what they found in their effort, led by Dr. Sterling, was that in fact, the viral responses were the same as in-person visits. Next slide. But at a tremendous savings to the Department of Corrections, and the tune of over $2.5 million in fiscal year 2021, estimated based on utilization prior cost estimates. Next slide. Another aspect of telehealth that has seen increased utilization here at VCU during the last year two is an example of Project Echo, which is a program designed to use and leverage the technology to share best practices largely throughout the community to improve the quality of care delivered to the individual patients across the Commonwealth, even if they are not necessarily coming to Richmond and VCU for their care, by improving the quality of the care they get from their other local providers. Next slide. So how is this, who is utilizing this program and how is it being utilized? Well, you can see here it's being used by a variety of Department of Medicine related clinical services: opioid, palliative care, sickle cell, hypertension, diabetes, nursing home outreach, and the like. Next slide. And through these means of communication from the experts here at VCU, through a variety of didactics and case management discussions, again, the providers in the local communities that have utilized the service are able to better care for the providers and the patients at their site of domicile without necessarily the hassles and the inconvenience or the barriers of travel to Central Virginia. Next slide. So sickle cell program, as you can see, similarly has a patient distribution throughout the entirety of the state, as well as patients that they reach out to in North Carolina, West Virginia, and parts of Maryland. So a hugely dispersed patient population that is at high risk for some serious complications. The team at the sickle cell program, as you may be aware, is led by Wally Smith on the adult side, along with Toko Lopato, India Sisler on the pediatric side, but has some great nurse practitioners that are very engaged with the patient care and management in the inpatient and outpatient settings, as well as pharmacy techs and 3 new patient navigators, social workers. But it is truly a multidisciplinary interactive clinic where they are engaged across the health system to improve the care of the patients, as shown here. And some of the benefits that they have seen to this collaborative multidisciplinary approach has been improved relationships with the payers, some of which they have formal arrangements already, so that they can do case management and optimal care. The patient navigators, which were sort of an offshoot of a clinical trial that was being done with hydroxyurea, was continued with the hiring of 3 full-time navigators, and allowed them to go into the patient's home with visits away from the clinical site here, and led to a greatly improved understanding of the socioeconomic and life experiences that improved the outcomes and the compliance and other behavioral aspects of the care. This was augmented by the social workers being added, again, that was able to really help address some of the social, economic, behavioral health barriers of the patients. In addition, some other great work that they've been doing over there was an infusion pilot that with the help of the nurse practitioners that they'd hired and guaranteed chairs over on North 8, they were able to demonstrate markedly reduced visits to the emergency room by handling acute pain during the daytime hours in the outpatient setting to hopefully avoid admissions. And this then, as a result, led to an improved time out of the hospital, as well as outcomes as well. And then, as noted, they too are part of the ECHO project. And so they do a monthly teleconference with providers across the Commonwealth and beyond. Another multidisciplinary clinic and center here at VCU that we're going to highlight is the Virginia Center for Coagulation Disorders, led by myself on the adult side and Gita Massey on the pediatric side, but really run by a phenomenal group of nurses, research individuals, social workers, physical therapists, geneticists, nutritionists, and the like, as well as our collaborations with OB/GYN, orthopedics, and the coagulation lab. We too are expanding and seeing great utilization of the services with nurse practitioners and fiscal administrators being sought at the present time. New paragraph or new slide. And like these, the sickle cell program, the mission of the program is really to improve the outcomes of the patients throughout the Commonwealth. We are a comprehensive lifespan programming. We go from cradle to grave, and we're the only such center in the Commonwealth of Virginia to do so. Funded entirely through grant program income through the 340B drug program, as well as sponsored industry trials. And highlight one that many probably are not aware are being done is we actually are a gene therapy infusion center for Spark Pharmaceuticals. So one of the few centers on the East Coast doing the gene therapy for this. Next slide. Another area of explosive growth in the outpatient setting is the examples coming out of pulmonary critical care, where, as you can see, their faculty, both physician faculty and APPs, have grown by almost 50% over the last 3 years alone. New paragraph, which has been done not just to expand the MRICU, but most to the point to greatly expand the ambulatory clinics and specialization and research programs and care delivery models in the pulmonary critical care space. So we've certainly had sustained excellence in interventional pulmonology led by Shepherd, as well as in cystic fibrosis, the program led there by Norman Chandri. Next slide. But we've now also seen more recently the expansion to other pulmonary subspecialty disorders with the pulmonary hypertension program led by Dan Grinnan, but really a collaborative effort amongst the providers and a variety of other specialists. The growth has been quite substantial, with 2021 being the first year on pace to exceed 200 patient evaluations, new patient evaluations. So great utilization of the service, and that the quality of what they've done is recognized by their now being recognized as by the Pulmonary Hypertension Association as a center of excellence for comprehensive care and the delivery of care to these patients. Next slide. Another new clinic, the Interstitial Lung Disease Program, headed by Dr. Perales, along with his team. Again, greatly seen expansion of services with nearly a 200% increase of visits per month during calendar year 2021 so far. So phenomenal rapid growth as they too try not just to care for the patients, but to increase the research and the education of the patients, the community, and our own providers here in the Commonwealth. Next slide. Similarly, sarcoidosis program headed on the pulmonary side by Amir Said and Tom Iden, but also with physician leaders throughout the department, rheumatology with Dr. Said and cardiology with Dr. Crone as well, leading to this also being recognized as a sarcoidosis center of excellence by WASOG. So again, attesting to not just the growth of services, but to the quality of the services being provided by all of you guys. Next slide. The most recent addition to the pulmonary portfolio this year has been the opening of the severe asthma clinic under the leadership of Dr. Mohan. And already in its short sort of existence, seeing some rapid landmarks being achieved with expansion to 2 different sites and the first administration of biologic therapy for the asthma out at Stony Point. Now, over the last 8 weeks, biologics being delivered now to 10 new patients during a relatively short period of time. And so continuing to growth as they develop a registry for severe asthma for VCU and the Central Virginia region. And finally, 2 other more recent additions to the pulmonary critical care space, the long COVID clinic and the global health initiatives with the outreach in Africa, as shown here. So as you can see, despite the disruptions of COVID through telehealth and through the necessity of thinking outside of the box on how to decrease hospital utilization, we've just seen a rapid growth opportunity for new collaborative programs, multidisciplinary approach. Next slide. Another example, the Women's Digestive Health Program, led by Dr. Esposito of GI Hepatology, really trying to target diseases that are disproportionately affecting women and trying to bridge the gap in the education, knowledge of the providers, as well as the clinical care being delivered in an academic research-oriented way. And they too are developing some phenomenal programs that are multidisciplinary in nature. A pelvic health program, a pelvic health program, a pregnancy-related program, and an early detection of cancer, as well as non-alcohol fetal liver disease. Non-alcohol fibrotic liver disease in women, with additional educational outreach by developing a women's health track within the GI fellowship and the first enrollee within the track of the trainees. So again, some really interesting work out there. And in addition, a survivorship clinic being opened through the Massey Cancer Center with Susan Hong, an internal medicine doctor who has specialized in general medicine, leading the effort to improve survivorship, but not in the traditional sense of survivorship after they've had the cancer, though that is certainly included, but also improving the care of the patients while getting the chemotherapy in a more active, ongoing sense, not just survivorship after the fact, but the assumption that survivorship starts on day 1 of the diagnosis through better management and collaboration with the chemotherapy to make sure everything is optimized. In addition, Dr. Hong is doing work with the geriatrics program to improve geriatric genetic screening in these patient populations. Next slide. One last ambulatory shout out is to the Autonomic Dysfunction Clinic, or the POTS Clinic, which, as many of you are aware, is a very challenging patient population. But this effort has been championed by Dr. Dom Sika, who has done a phenomenal job and has an incredibly loyal patient base who will sadly miss him upon his retirement in January of 2022. And certainly beyond the providers and the multidisciplinary teams, the advanced practitioners of the Department of Medicine are an incredibly large presence and growing presence, with over 144 nurse practitioners and APPs. Next slide. within our department. Thomas, you can go to the next slide. So as you can see here, we have not just a tremendous number, but we have a tremendous knowledge base with the nurse practitioners, some of whom have now exceeded 20+ years of service within VCU, as you can see here. So we give a huge shout out to many of our nurse practitioners and other advanced care providers, practice providers that are so integral to our system. Next slide. As this one fades in, Pat Selig had Thomas is advancing. There we go. Giving some special shout outs to some recent accomplishments as shown here of many of some of our advanced providers. Next slide. So Georgia.
Yeah, so thanks, Christian. I think this is a good opportunity just to highlight some of the things that we've been doing in quality and safety. I really just wanted to touch on a couple projects that we've been doing in different domains, the institutional priorities. And I will say that this is by no means a comprehensive list of all of the things that are going on. But I thought that it was a good way just to highlight some of the things that have been going on in the realm of safety, mortality, readmissions that has now transitioned to access and capacity, and in the patient satisfaction now, patient experience realm. So one of the projects that we're really, that has really been transformative in the health system, and that you will be more in touch with by the transition to Epic, is with the Pico project, Partnering and Communication Optimization. Many of you might remember Dr. Steve Biederman and his team in hospital medicine really wanted to understand and improve the communication that goes out to providers. This actually was spurred by a serious safety event that occurred in which the communication and the level of triage wasn't really communicated in a way that the receiver could really receive it well and to be able to triage their work. And so really the goal was to reduce the variability in our current paging process and really to standardize that communication and escalation so that everybody knows what their expectation is and how to really communicate a need to the provider. So when they looked at the components that every page should have, it really needs to have 5 different pieces. So a priority label, a sender name, a callback number, the patient name, and the concern. And so if you go to the next slide, this team looked at over 3,000 pages. They weaned out some of the pages that were more social or not really directly related to patient care, and were able to wean it down to 1,800 pages to really assess how compliant folks were with using all 5 of those pieces of data. And as you can see, only 14% of pages that were sent that were directly related to patient care had all 5 components. For the most part, people had the sender and the callback number, but the priority, which was really the thing that the provider needs to know in order to really structure their work, was only there in 32% of the pages analyzed. And so they were able to take this work, surveys from providers, surveys from nurses, to really pivot to that project. How do we improve the communication in our health system? And so they actually started on one unit. You can go to the next slide. They started on one unit to really improve that communication. And this project was so well received and far reaching that the health system patient safety department really saw this as an institutional priority to really say, we need to change how we're doing paging and educate people on the different levels of pages, as well as how to escalate appropriately so that the right people get to the patient at the right amount of time. So we're really proud of this. It was really changing, and it's going to be changing our practice across the health system. And it's not just in one department, but really throughout everybody as we're changing to Epic. And if you go to the next slide, this shows the new communication and escalation procedure. And all of these documents are now on the procedure and policies website on the SharePoint site, so you can access that directly. But hopefully it helps people to really be able to streamline who is paged, what other resources might be available, so the clinical administrator, RRT, that kind of stuff. And it gives a little bit of guidance in terms of timeline, in terms of if it's an urgent, really a life or death situation, what that timeline should look like and who should be contacted. So again, started in our hospital medicine quality group and is now spread throughout the health system. The next slide. So, and just to, again, quick highlights on some of the projects that we've been doing. So in mortality, in fiscal year 2021, we actually noted an increase in our mortality O to E, which was actually a difference in terms of our previous year's performance. As you can see, in 2020, we actually had an O to E of 0.73, but actually increased to 0.80. As you know, that a lower O to E is always the goal, the observed to expected mortality ratio. And so when we looked at really those cases, we saw that a lot of them really were based in our patients that hit the MRICU, recognizing that we have a very complex patient population, and really they come to us for help at that end stage of their disease. And so the goal was really to look at those patients, but specifically to look at patients that had a below expected mortality rating. So not those folks that we knew that probably there's not much to do, but really the patients that were really not expected to die in our healthcare system. And we excluded patients with COVID. So next slide. So this was a group, a huge effort using a select group of folks from the Pulmonary Critical Care Division to analyze 37 cases that was from January 2020 to March of 21, to really understand if there's any themes that could be understood from these patients that unexpectedly passed away. And we actually did a pretty robust review based on some of the questions that our hospital-wide mortality review committee uses. And if you go to the next slide, I'm not going to give you all of that data, but one of the things that was discovered was when we looked at the cases, that there were many cases in which a delay in treatment or failure in recognition of care were identified. And actually, when we look at these delays and failures, there were actually overlaps in multiple cases. So delay in diagnosis or misdiagnosis, most frequently it was with sepsis, either a delay in recognizing sepsis or delay in giving antibiotics. And so that next slide, we've proposed a few interventions, hopefully as the census and as we get out of our Epic transition, that we will be able to focus on this. But potentially things that could help with this is to look at those patients that bounce back from the ICU, to do a selected review and following of those patients with our intensivist team, to review patients that are on high flow oxygen, and to have an automatic consult with an intensivist to really monitor those patients, And then to focus our education on sepsis and early rescue of patients, as well as those patients with hypoxic respiratory failure. So something that we're working towards, again, once we get out of our kind of current surge and current capacity needs, but things that we're thinking about that might help drive down our mortality rate. And then the next slide. And then quickly, just to highlight some successes that we've seen in our HEMONC clinic. So we're always looking to reduce readmissions to aid our patients that are maybe with new complications, so specifically patients that have a new diagnosis of cancer. And the one intervention that was done was to create this HEMONC Priority Care Clinic staffed by some of our APPs. And if you go to the next slide. Between December of 2020 to August of 21, 138 patients were seen, and a large amount of those patients, 86% avoided the emergency room, 84% avoided an inpatient readmission. So really impactful in terms of providing care for those patients and hopefully helping to reduce their inpatient service utilization. And this clinic has actually helped our med-onc service to exceed the performance in terms of reducing readmissions for this group of patients. And then the next slide. So just to finish off on the patient experience, so our cardiology group has done a lot of focused work on improving the patient experience in terms of patients that come into cardiology, either on 10 West or in the CICU. They've done a lot of work with proactive rounding on a group of patients, cohorting patients per nurse and per care partner, increasing their responsiveness of their that call bell. And so they were actually able to really drive their improvement in terms of patient experience significantly, so that they're actually one of the top in the top 10 quartile or percentile within the nation. So something that is really great with a small intervention that was done on 10 East in the CICU. So again, these are just a couple examples of some projects that were done in the different priority levels or priority projects in the institution. And I want to leave you with that one further slide, the last slide. I think everybody has been able to see the monthly newsletter. So again, just a way to give information, communicate some of those projects, and just to celebrate some of the work that we've done in quality and safety over the year. Thanks, Christian.
Have the next slide, please. Thank you. And maybe we'll just finish off in the place where we should, which is really just to acknowledge the tremendous work of not just everyone, but certain individuals who really did sweep the floor in terms of both university and School of Medicine awards. And, you know, we have to recognize that these are the individual people that have been nominated, but the competition for these awards is very strong. So starting out with Dr. Ger, of course, who received the MCVP Distinguished Clinician Award, very deservedly so. Dr. Michelle Brooks, who was the happy recipient of the Irby James Clinical Teaching Award. The Distinguished Mentorship Award went to Amir Tor. And in the VCU side, Alan Dow was the VCU Distinguished Teaching Award for the entire VCU system. Christian Barrett received the Gertz Teaching Excellence Award, and very fitting for his role as Interim Associate Chair for Education. And then the School of Medicine Education Innovation Award went to Dr. Megan Lemay and Dr. John Nessler. And the Program Coordinator Award went to Alison Dubinsky. So again, many congratulations to these individual folks. And it really is you and the staff, the faculty, the trainees, our APPs who really make this department successful and importantly deliver great care to our patients. You know, I think as you see, we do lots of different innovative things. It's a very busy department. You know, we've done tremendous work, I think, during COVID and all sides of COVID. So I look forward to the next year I think lots of things to work on. We'll continue to work on our safety missions, as well as delivering great care. So thank everyone for joining today. Apologies for a couple of hiccups with the audio visuals, but happy for the panel now to take any questions from anyone.
Thank you to our speakers. That was wonderful overview, and I don't know how you were able to capture so many success stories. Thank you all for your work. Reminder, we'll take questions here for a few minutes. If people have any questions for the panelists or overall comments, welcome to stick around for a few minutes. Thanks for your time. You can also raise your hand if you want to be unmuted.
We just want to remind everyone as well, obviously our EPIC rollout is a big event, just a couple of weeks away for us all, and many different people in the department have been working very hard to try and make this as smooth as we can. You know, I think things are never going to be perfect, first off, but I think, you know, we'll get through this together and make the necessary adjustments as we go, kind of learning from the system. It is a really good system, and I think, you know, once we get over the initial transition period, you'll really enjoy working in it. It's easy to take care of patients with the system. So between that and the opening of the AOP, it's a very exciting time in the health system, and as always, as the biggest department, we have some of the biggest load in all of this. Make sure you be trained, otherwise you can't access EPIC. I think we've got almost everyone trained, but you can't get access until you're fully trained.
We'll give folks a few more minutes to submit any questions or raise your hand if you have any questions about clinical obligations or concerns.
All right, well, I think everyone knows where we live and can reach out to us. And please do reach out if you have any particular problems with EPIC in particular, and we'll get you the assistance that anyone needs. But thanks to all the presenters today, and thanks to Christian for putting this together.
Thank you all so much. I hope everybody has a good day. And a reminder, we will not have grand rounds next week. It is Thanksgiving, so happy early Thanksgiving. And thanks for everybody who continues to cover clinical services during the holidays. Thanks for your time, and we'll leave the screen up for attendance. The CME code and the QR code is on, and we will see you all back in 2 weeks on December 2nd. Thank you all. Appreciate it.